directly starting the aspects. We all love to give osimertinib in EGFR mutant patients, but why? As already discussed, it is well tolerated, oral treatment, very good outcomes. Bracket usually. Issue affordability. Generic not going to come patent till 2035. So that is an issue for us. How many patient of us are actually able to receive this drug? Though we all as a medical oncologist love this drug, giving this drug. So what are the alternative strategies available? JEF plus chemo. Yes, it is our own trial and this is very close to our heart and we'll talk in detail about the same. TKI plus metformin. Yes, we have some data from our institute as well. And also there is a lot of data, multiple phase 2 studies from various parts of the world. TKI plus BEV. Yes, TKI plus BEV and TKI plus ramucirumab. For both there is data. We'll see that as well. So this is the content of my slides. So let's start with the star presentation. Professor Vanita Noronha, this has been most talked about presentation. Now OMCT plus immuno is being, low dose immuno is being talked about. Similarly, in 2018, this was the most talked about presentation in the ASCO. So this is all as medical oncologists, we are aware of this slides and this aware of how this trial was designed. The key highlight points which I wanted to show here, the PS2 patients were also included in it. And this is very, very near to actually what we practice in our settings. Asymptomatic CNS mets were also allowed. Again, we'd like to highlight PS2 were also allowed in this study. So this is very, very likely a real world status of patients. JEF plus chemo versus Jeftinib alone. Treatment continued until progressive disease. Primary endpoint of PFS, secondary endpoint of overall survival and toxicity. So again, I would like to highlight rare mutations are also included, but caveat, these were very small numbers. Rare mutations were not allowed in many other studies, but in this study it was allowed. So this is the slide which we all like to see, a wide separation of the curve, which is starting from the baseline. You can see the separation in the curves are starting as early as 3 months. That is the time of usually first analysis which we are doing, first assessment we are doing. And the curves remain separated through a long time and continue to remain separate. That is what we like to see as a oncologist. Similar data is also for oral survival as well. In actually, if we see the PFS difference, it is 8 months versus 16 months. What better we can get with Jeftinib combined with chemotherapy, 8 versus 16. Similarly, OS, if it has not reached overall survival endpoint, so at 18 months, OS was 48%. Versus 75%. To remember it correctly, I need to counsel my patients. So I need to give some numbers, especially the patients who are well aware, well read. 48%, 18 months PFS, 18 months OS versus 75%. This is the ballpark figure which I try to remember in my practice. This is the overall response differences, waterfall plots we like to see. You can see only one patient had progression, while all patients had response in JEF plus chemo, while in JEF alone, we know, yes, some patients progress on it. So this is the curve which we have already taken. There's a concept of PFS2 as well, because this is when this paper was submitted in the JCO, there was first comment by the reviewer which we got was, how would you assess the PFS2? Because the patient has already consumed both chemotherapy, which is the first line chemotherapy, pemetrexed plus carboplatin, and also a TKI. Is PFS2 different? So PFS2 is still in favor of JEF plus chemo arm. So we remain assured that it is not due to the problem with utilization of chemotherapy, and we can rest assured. And the difference is not stemming due to utilization of all the drugs, but it is due to delay in appearance of resistant mutations, which is basically driving this. And all the subgroups are getting benefit. You can clearly see whether the gender, exon 19 versus others. This is an important slide because this was previously thought that some TKIs work well on exon 19, while others do not work. But with utilization of JEF plus chemo, you can clearly see both exon 19 and others are getting benefit. Also, PS0 to 1, yes, it is very well separated. Even PS2, it is not crossing confidence interval 1, it is 0.98. So even well-selected PS2 patient, this can be considered. However, I would like to be cautious about the same. I will come to that, the toxicity part. So any improvement in the benefit comes at the risk of the toxicities. So what are the toxicities? It is doubling of the serious clinically relevant toxicities from 25% to 50%. What are these toxicities mainly? Chemotherapy-induced myelosuppression, yes. Around 11% patients had febrile neutropenia. You should be ready to manage that, and you should explain the patient that this is going to happen. And also some amount of nephrotoxicity is seen. This is very common because when we utilize even pemetrexed, we know some patients will develop toxicities, nephrotoxicity. Fatigue was not statistically different in the trial, but in my clinical experience, I found patients to be having significantly more fatigue in patients who are receiving GEF plus chemo, especially till the time patients are receiving carboplatin as well. When the patient shift to gefitinib plus pemetrexed maintenance, I find fatigue to be acceptable. So this is what the clinical data suggests. This is what clinical experience suggests. So there have been multiple other studies. NEJ009 study was there. This has also been very talked about. It included only PS0 to 1. This is a difference from our own trial, which should be taken important. And also this study had very detailed exclusion criteria that happens very well planned randomized trials of the West and the East. This is what happens. But in our trial, it was more of real life scenarios. So again, similar curves. Gefitinib versus GEF plus chemo, a significantly improved overall responses. PFS, PFS2, OS, all are seeming to getting benefit. So NEJ009 also stamped that GEF plus chemo is a good option. So this again, PD1 and PD2, which I wanted to highlight here. This is the tumor burden, which is coming down with the combination of GEF plus chemo. And if you're GEF alone, this is first progression, then utilize second line chemotherapy with platinum agent. Again, there is some decrease, but again, there is progression. But still, the difference is that even utilizing chemotherapy in the second line, you are not able to reach the survivals which GEF plus chemo is able to give in the first line. So that is how I see this trial and our own trial in our real practice. Now, there's data for erlo plus bevacizumab as well. There is some improvement in survival PFS from 13.3 to 16.9 months. Some improvement at the cost of toxicity, at the cost of extra expenses. There is a relay trial. It is ramucirumab plus erlotinib data. You can see a wide separation in the curve, 12 months versus 19 months. Yes, this seems to be interesting. And where it is working well, I would like to highlight here. So exon 19 deletion and exon 21. These two are very different subgroups. This need to be understood. On exon 19, every drug is working well. It is inherently a good prognostic group. But what is happening to exon 21? All drugs are not working well on exon 21. And here this data is clearly suggesting that exon 21 patients are also having good response to this regimen. So this is important to understand why this is happening. Exon 21 mutation patients have multiple co-occurring concomitant mutations, and co-mutation rate is 65 to 70% with L858R. With exon 19, it is only 40%. So definitely, occurrence of co-mutations is the main problem with exon 21 that needs to be taken care of. Sometimes TKI alone cannot tackle it. You need to either add chemotherapy or you need to add some treatment like ramucirumab. So TKI plus chemotherapy or TKI plus ramucirumab is the preferred treatment for us when high-end molecules which are usually not affordable in our setting. So the preferred combination remains the same. There are some now coming to some data for bevacizumab addition to chemotherapy. There is some improvement, but we are not convinced this data. We usually do not use in our routine practice in our settings. Let's come to metformin. This seemed to be a very intriguing studies. There were 2 phase 2 studies which showed very, very good data. So this is one of the phase 2 study published in JAMA Oncology. You can clearly see there is some separation in the curves and it is starting again very early. The problem is that the study was comparatively small with 70 patients in each arm, and but still it was worth considering. So there were further studies. This is the another study, larger study with 224 patients. Yes, it was a large number. There was PFS difference was not significant. OS difference was numerically, in fact, lower in the metformin group. That was a problem, and overall response rate was similar. So this study sealed that addition of metformin doesn't benefit the patients. So to conclude in brief, choosing wisely remains the key. it is not a single regimen which you can tell that this is the best for any group of the patient. You need to individualize the treatment for your patient, see the various co-mutations if possible. So even doing NGS is useful in some patients. As I talked in the molecular tumor board in a few hours back, even exon 19 deletion is different. If you think exon 19 deletion is a same thing, no. Exon 19 deletion can be from 745 to 759. Usually 745 to 749 is the exons which are involved, but exon 751 to 759 which are involved in exon 19 deletion have different outcomes. Utilizing different TKIs is important in those patients, and there is enough data for the same as well. So with this, greetings from Team H Varanasi. Hopefully we will be calling all of you to Team H Varanasi for a next meeting. Thank you.
Thank you.